Hi everyone, welcome to the National Hispanic and Latino ATTC's webinar, Hepatitis C and Hispanics in the United States. Today's webinar will be presented by Drs. Claudia Martorell and Janet Hernandez. I will tell you more about them pretty soon. During today's webinar, all participants will be muted. The audio will be streamed through the computer, so please make sure your computer speakers are turned on and off to hear today's presentation. Now I'm going to review a few housekeeping items with everyone. If you notice that your viewer does not fit your screen, you can expand it by clicking the expand button located on the top right corner indicated by the red arrow. Now you'll see that your viewer is expanded to fit the entire screen. Also, you can collapse the GoToWebinar toolbar on the right of your screen by clicking on the small red arrow on the left of the toolbar. When you click it again, it will expand. As I mentioned, for today's webinar, all participants will be muted. As we move through the presentation, if you have a question for a presenter, we ask that you use the chat box on the toolbar. Simply type your question and hit send. What we're going to do is we're going to leave a few minutes at the end of the presentation for our questions, and if we don't have enough time to answer all of the questions, we'll post the answers on our website. A recording of today's webinar along with the PowerPoint slides will be available at our website www.ATTCnetwork.org/Hispanic Latino approximately 1 week from today. So if you go to our website, you'll also find recordings and PowerPoint slides from all of our past webinars at the same URL. One NADAC, one MVCC, and one ICRC continuing education credit is available to those who attend today's live event. So if you're interested in obtaining CEUs from these organizations, you may email us at hispaniclatinoattc@uccaribe.edu. Today's webinar is sponsored by the National Hispanic and Latino ATTC. As of October 1st of 2012, the network has been restructured and now consists of 10 regional ATTCs, 4 national focus area ATTCs, along with the network coordinating office. As you can see by this map, the ATTC network regions were realigned to better fit the current HHS regions. And the 4 national focus area ATTCs are right here on the left. Today's webinar is the 24th in a series that the National Hispanic and Latino ATTC has been offering. The ATTC network is funded by the Substance Abuse and Mental Health Services Administration and serves a critical role in improving the health of the United States. The network achieves this by translating, disseminating, and promoting the adoption and implementation of evidence-based clinical practices and strives to improve the health and wellness of individuals whose lives have been impacted by substance use disorders. You can learn more about the network's product and programs by visiting attcnetwork.org. As I mentioned, the ATTC network is funded by SAMHSA. SAMHSA strives to reduce the impact of substance use and mental illness on America's communities through its programs and services, and demonstrates that behavioral health is essential to health, that prevention works, treatment is effective, and people recover from mental and substance use disorders. If you want to learn more about SAMHSA, you can visit their website, www.samhsa.gov. Now let's meet our presenters. Dr. Claudia Martorell is an infectious disease clinician and clinical investigator with a Master's of Public Health in Healthcare Management and a fellowship in health policy and minority health policy from Harvard University. Dr. Martorell currently serves as the director and principal investigator of the Research Institute in Springfield, Massachusetts, where quickly she became nationally recognized for her leadership role in HIV and HCV research and treatment in minority populations, her compassionate medical care, and for her long-standing commitment to serving the underserved in the medical and public health field. She has published in major journals. Dr. Martorell was the recipient of the 2007 Severo Ochoa Award for Outstanding Contribution to eradicating HIV/AIDS in the minority community, and the recipient of the 2004 American Medical Association Foundation Excellence in Medicine Award. That's Dr. Claudia Martorell. Now Dr. Janet Hernandez. Dr. Hernandez earned a Bachelor of Science in Human Services from Springfield College and a Master of Education with concentrations in Counseling Psychology and Addiction Studies from Cambridge College in Massachusetts. His doctoral degree was earned in the School of Public Health and Health Sciences at the University of Massachusetts, Amherst. His major was Community Health Education, and his minor was Social Justice Education. In addition, Dr. Hernandez holds an advanced certification in drug and alcohol counseling at the reciprocal level, is licensed in Massachusetts, and is a certified prevention specialist. Janet is a person in long-term recovery from addiction and is committed to eliminating health disparities by working at the national, state, and local levels. He is currently a senior consultant for the Massachusetts Department of Public Health Bureau of Substance Abuse Services with a focus on access to recovery, recovery supports, and the recovery support centers. He has served as a consultant to several federally funded initiatives in the area of behavioral workforce development, HIV/AIDS, addiction prevention and treatment, military service members, their families, and TBI and PTSD, and pediatric asthma. He serves as faculty at the New England School of Addiction Studies since 1998, has taught a number of undergraduate and graduate courses, and has presented at several national and state conferences. Okay, so these are our presenters. Before we continue, I want to mention again that if you have any questions, you can use the chat box, type your question, hit send, and we'll be able to pause at the end of the presentation to answer your questions. Before we begin the presentation, we're going to do a poll questioning to get to know our audience, and we'll do a pre-test as well. So our first question: do you currently serve Hispanic and Latino populations with substance use disorders? And 85 of our participants say yes. Are you planning on serving Hispanic and Latino populations with substance use disorders in the next 6 months? And 80% of our participants say yes, 13% no, and 12% don't know. What is your current professional role? Okay, so here we have 40% social work, case manager, 14% counselor therapist, 5% faculty, 14% government policymaker, and 29% other. What type of setting do you currently work in? Okay, so we have 6% academic, 41% treatment, 5% research, 21% government, and 32% other. Now we move on to our pretest. In terms of mortality, Hispanic patients with HCV in the United States, and we have that 33% say higher mortality rates um, from HCV related, 60% all of the above, and 15% mortality cause has been letter C. Okay. Hep C, 63%, 67% is occurable in more than 90% of patients. 24% chose letter B, it's a virus, and that infects only the liver. 10% chose C, cannot be sexually transmitted. And our last question. In terms of treatment, %10 chose letter A, must include interferon. 19% chose letter B, last 6 to 12 months, and 71% D, decreases liver-related and overall. Okay. So that's it for our questions. Now I'm going to leave you with our first presenter, Dr. Claudia Martorell.
Good morning. So I am going to be giving an overview in terms of hepatitis C in general and how it affects people in the United States, later specifically among Hispanics, the gaps, barriers in care, and then the understanding that hepatitis C is a curable disease. And I think it's important to understand that it can be cured nowadays in more than 90% of the people who undergo treatment, and then the importance of screening, diagnosing, and referring patients right away. And I'm going to start with a case because I think this case illustrates the main barriers in terms of potential screening, diagnosing, and treatment in terms of hepatitis C. So this 55-year-old male, a patient born in Puerto Rico, was diagnosed with hepatitis C in 2008 during a routine screening by his primary care when he moved to Massachusetts. And that's usually how hepatitis C gets diagnosed, by routine screening, because most people will not develop any symptoms of yellowness of the skin, nor abdominal pain, nor vomiting. Most people will not develop symptoms, so usually they get diagnosed when they go through screening, and we'll go over that later. Mode of transmission was intravenous drug use. He has not been using drugs for 3 years. He's on Suboxone. He does drink alcohol socially. So, you know, he would be a perfect candidate because he has been not doing any drugs, and he's on a stable Suboxone program. And it is always important to address what does social alcohol use mean, because in terms of treatment, people should not be drinking at all while they are on hepatitis C treatment. However, alcohol will not lead to hepatitis C. Alcohol may cause liver hepatitis or alcoholic hepatitis, but will not cause hepatitis C. Hepatitis C is a virus, it's an infection. Alcohol will not cause infection. This patient is married, he has 3 kids, he's monolingual, Spanish speaking, so he doesn't speak English. And in terms of marriage, it is important because hepatitis C can be transmitted sexually. It is not the most common way of transmission, but it is important to know that it can be treated or transmitted sexually, so his partner should be tested. there has been a recent sexual epidemic in men who have sex with men, in particular patients with HIV. So it is important to understand that it can be sexually transmitted. This person is on disability for depression. He has diabetes and has high cholesterol. And the reason why this is important is because a lot of people with hepatitis C have comorbidities and they may be on medications like this patient. And that is important because of potential drug interactions with the hepatitis C medications. And hepatitis C affects the liver, but it may also affect other body organs. It does not only affect the liver. So for example, his diabetes may be exacerbated or hepatitis C may be contributing to his diabetes. He has been referred to a hepatitis C specialist, but he did not show up to his appointment in 2009 and 2011 because he was feeling well and he did not want to be treated with interferon, and that is a very common barrier. People, again, do not have symptoms. Most people do not have symptoms and they do feel well and they do not understand what hepatitis C can do to their bodies, and they do not want to get a treatment that they do not understand, especially the older treatments like interferon, where it could cause side effects that were not very pleasant. However, treatments have changed, and interferon is not part of the current treatment modalities for hepatitis C right now. So in terms of hepatitis C itself, he has genotype 1A, which is the most common type or subtype in the United States, has hepatitis C detected in his bloodstream, 4.5 million or international unit or copies, which is an indication for treatment. He has liver fibrosis. So even though he has no symptoms at all and he feels well and he has normal liver enzymes, his liver already has evidence of scar. So he should be treated before that liver becomes cirrhotic or completely scarred. No evidence of cancer. Cryoglobulin positive and his lower kidney function means that the hepatitis C is already affecting his kidney. Again, hepatitis C will affect the liver, but also affects other body organs. He has no HIV, he has no hepatitis B, and no hepatitis A. He has evidence of hepatitis A history in the past. He doesn't need the vaccine, but he will need the hepatitis B vaccine because he has no evidence of hepatitis B exposure in the past, and he should get the vaccine so that he doesn't acquire hepatitis B as well. So in general, that tells you a little bit of the potential issues and factors that providers need to be looking at in terms of someone that comes in for evaluation. Hepatitis C, again, is a virus. It's an infection that may cause severe liver inflammation, damage, and death. And it will affect other body organs besides the liver. It's a systemic infection. So alcohol will not cause hepatitis C, or fat in the liver will not cause hepatitis C. Fat in the liver may cause fatty steatohepatitis. Alcohol may cause alcoholic hepatitis, but not hepatitis C. Hepatitis C is an RNA virus that was used to be known as non-A, non-B hepatitis until 1998, where it was designated as hepatitis C. There is no vaccine available for hepatitis C, and that's why there is so much people affected by hepatitis C. And there is not that much hepatitis B anymore because there is a vaccine for hepatitis B. And people who has not received that vaccine should get the vaccine. And hepatitis C can be cured, and the cure rates are more than 90 with the new treatment modalities that are available right now. In terms of what happens when someone gets infected with this virus, they develop acute hepatitis C infection, and that usually may last up to 6 months. And what happens is that in a minimal amount of patients, in less than 1 out of 100 people, some people die from that. They get significantly sick with yellowness of the skin, distended abdomen with ascites or fluid, leg swelling, fever, vomiting, and they die. Most people will not die from that. In about 20 out of 100 people, they will get cured by themselves without the need of medications in about 20 out of 100 people. In 80 out of 100 people, those patients will develop chronic hepatitis C. And that happens when the person has had the infection for more than 6 months and they were not able to clear the infection by themselves. And those are the patients that need treatment with hepatitis C medications because they will not clear the infection by themselves. And the earlier they get treated, the better, because that means that the less likelier they will develop complications related from hepatitis C, such as liver cirrhosis, liver cancer, liver failure or hepatic decompensation, and death. And not only liver-related complications, but also extrahepatic manifestations or non-liver related complications such as kidney, chronic kidney disease, or earlier development of diabetes or bone problems or cardiac problems or worsening of depression, among other things that I'll show you in a later slide. Medications, again, one of the main barriers for treatment has been the older medications. Treatment used to be 6 to 12 months. That has changed now. Now the treatment is 8 weeks to 24 weeks. The treatment used to be with interferon, then interferon and ribavirin, then pegylated interferon and ribavirin until 2011 when the direct acting agents were approved. And in the past 2 or 3 years, there is no need for interferon in most situations in terms of when people need to be treated for hepatitis C. Since then, since the lack of need for interferon, the cure rates have gone significantly high, more than 90%. The length of treatment has decreased to 8 weeks to 24 weeks, and the side effect profile has also improved significantly, making more people be willing to get treated. What happens? People cannot be treated if they don't even know that they have the infection. So it is estimated that 3.5 million or even 3.7 million Americans have chronic hepatitis C, and half of them do not know they have it. Why? Because they don't have symptoms. And when people develop symptoms, it may be like a cold, like a flu-like illness where they don't necessarily go to a doctor or provider to get checked for. And because there are so many barriers for treatment, especially previous treatments, and few providers treating, especially in the past, 9% of patients were treated or cured successfully. Genotypes. There are different subtypes of hepatitis C, and it is important to know because based on the subtype is the treatment that is offered. Not everyone needs the same treatment nor length of treatment. There are different varieties or different factors that we use to determine what would be the appropriate treatment for the patient. Genotype 1 is the most common genotype in the United States, especially in particular genotype 1A, but there is also genotype 2, 3, 4, 5, and 6. In the United States, hepatitis C is the leading cause of liver transplant and liver cancer, and a shorter lifespan, increased mortality. And hepatitis C has a mortality rate that has exceeded or exceeds the HIV mortality rate, and that happened after 2005, as you can see in this graph. These are examples of how hepatitis C can affect other organs besides the liver. And again, a lot of it is autoimmune. So, for example, like I mentioned before, kidney, hepatitis C has been associated to lymphomas, such as B-cell lymphomas, skin conditions or rheumatologic conditions, porphyria cutanea tarda, neuropathy, which are a nerve pain, vasculitis, thyroid problems, pulmonary problems, like I mentioned, kidney disease, exacerbation of diabetes, vasculitis, and a lot of people complain of pain, arthritis or arthralgias, kinds of things, and problems with platelets, hemoglobins, and white cells. And importantly, hepatitis C or chronic hepatitis C has an impact on health-related quality of life. And it has been reported that there is a lower health-related quality of life in patients with hepatitis C. So in general, people with hepatitis C compared to people who do not have hepatitis C, they report more body pain, less happiness with general health, physical functioning, social functioning, among others. And there is a higher number of comorbid illnesses, including depression and anxiety. And depression has been found to have an impact on the quality of life and health-related quality of life. And also direct costs and indirect costs, such as emergency room visits, lost wages, and productivity has an impact and is higher than in patients with hepatitis C compared to patients with no hepatitis C. And SVR, which means cure, SVR means sustained virological response, and that is the medical term for cure. When someone gets rid of or cured from hepatitis C, that has been associated with an improved quality of life. And this is an example of a data set, but there are several data sets that show the same findings or similar findings. And essentially, when people get cured compared to people that do not get cured after treatment, they show improved function. So for example, less body pain, improved genital health, physical function, social function, mental health, among other parameters. Besides mental health and physical health, of course, when people get cured from hepatitis C, that leads to decreased complications and mortality in things like liver cancer, hepatic encephalopathy, and bleeding from varices, and of course a decreased or reduced risk of all-cause mortality, so liver-related and non-liver-related mortality. And why can hepatitis C be cured and HIV cannot? Hepatitis C can be cured because the hepatitis C is an RNA virus where the RNA will never go inside the nuclei of the cell and it will not get integrated. It doesn't integrate inside the genetic material of the, the DNA, the human DNA. HIV, for example, the HIV is an RNA virus as well, but when it gets inside the human cell, it becomes DNA. So the body recognizes the HIV as part of our own cells, and that HIV then gets inside the nuclei and it gets integrated. It integrates into our own genetic material. So that is the main difference between those two viruses. So the medications for hepatitis C are able to target directly the hepatitis C viral RNA, and it won't affect the human DNA or the human cells. And they directly inhibit replication or multiplication of the hepatitis C RNA. People need to be tested or screened, because what I said earlier is that half of the people who have hepatitis C, they don't even know they have it. And they don't even know that hepatitis C exists. And if someone knows it exists, they don't even think they need to be treated. So there are different sets of guidelines, but they all agree that regardless of risk factors, the baby boomers should be screened at least once. And baby boomers are people born between 1945 and 1965. And the reason for that is because 75% of all hepatitis C patients are baby boomers. The highest prevalence of hepatitis C has been found to be in baby boomers. So they should be screened at least once, even if there is no risk factors identified. In other populations, you go by risk factors, which are the older guidelines that we have always followed over time. And these would be people who have ever injected illegal drugs, even if it's once, even if it's crack cocaine, HIV-infected patients, patients who have received tattoos from unlicensed or unregulated environments, anyone who has had any kind of transfusions or clotting factors before 1997 or 1992, patients who are on long-term dialysis, organ transplant recipients, healthcare workers after any kind of needle stick, sharp, or mucosal exposures to hepatitis C positive blood, and children born to hepatitis C positive mother. And remember what I said earlier, if there can be hepatitis C sexual transmission and exposure. So if you know that that may be happening, those patients or those should be tested or screened as well. And then how do you diagnose hepatitis C? So there is a hepatitis C antibody test, which is a screening test. And if that screening test is negative, the patient has not been exposed to hepatitis C unless the exposure has happened within 6 months. In that case, the person should be retested, or that person should have a hepatitis C viral load PCR test, because sometimes it takes the body to create antibodies a few weeks or months. So if a person has been exposed to hepatitis C virus, if I get exposed today and I get tested in a week from now, my test is going to be negative because my body has not had enough time to create antibodies, which is what the test would detect. So if my test results are positive, if the antibody test is positive, that means that I have been exposed to hepatitis C. It doesn't necessarily mean that I have active hepatitis C. It could mean that I had it in the past. It could be a false positive result. So in that situation, I have to confirm the diagnosis. I cannot tell someone that they have hepatitis C only with that test result. In that situation, I have to do a hepatitis C RNA PCR test, which would tell me how much virus the person has in their bloodstream. If there is virus detected, then I know that that person has active chronic hepatitis C. And if that is the case, that person should be treated regardless of what of liver enzymes. In terms of the Hispanic and Latino population with chronic hepatitis C, the hepatitis C prevalence is between 1.5% and 2% depending on the data set that you look at. And this data set is from the National Center for Health Statistics and the National Community Health Study and the Study of Latinos. And, like I mentioned earlier, the baby boomers, right? Men 40 to 69 years old of age have the highest prevalence rate. And if you look to your graph on the right side of your screen, you will see that, Hispanics and Latinos are diverse. And in certain places of the United States, you will see the prevalence change depending on the demographics. So for example, if you look at the Bronx and in Chicago, you will see a higher prevalence of Puerto Ricans that are affected by hepatitis C. In the Bronx, about 15% of male patients affected with hepatitis C are Puerto Rican. And you can see also some women, a higher prevalence of Puerto Rican women in the Bronx. In Chicago, higher prevalence of Puerto Ricans and Dominicans, people from Dominican Republic. If you look, for example, at Miami, you can see that there is a little bit of a higher prevalence of Cubans. So it goes a little bit with the demographics in the United States. And you may see some people from South America or Central America in some other areas. In Mexican, for example, San Diego, you see a higher prevalence of men and women in the Mexican subpopulation in San Diego. And one of the questions that you had at the beginning before the presentation goes into Hispanics and mortality. So there is a data set in 2007 that shows that Hispanics have the highest risk of hepatitis C related mortality versus other races or ethnic groups. And the association of chronic liver disease with hepatitis C infection as mortality cause has been shown to be greater in Hispanics than non-Hispanic whites and non-Hispanic blacks. And barriers to care and adherence, and this applies to minority populations, including Hispanics. And there is healthcare system factors, social economic factors, therapy-related factors, condition-related factors, and patient-related factors. And I will tell you the ones that I believe affect the most or have a higher impact in terms of barriers to care. So if you think about health systems, provider-patient relationships and mistrust of healthcare professionals has a big impact because a lot of patients may perceive that some of these, they may be like guinea pigs, or that these medicines may have toxicities and that they may not need these medicines, or they may not trust the healthcare system or even the providers, or they may even believe more what the neighbors or what someone else tells them rather than what the provider is recommending or telling them. In terms of condition-related factors, lack of symptoms has a huge impact. Again, hepatitis C in most situations, the person has no symptoms up until it's late, right? When people have findings of cirrhosis, that's when people tend to develop abdominal swelling from ascites, the leg swelling, the vomiting of blood, those symptoms, and it might be late already for treatment. Before that happens, people tend to not have much symptoms, or if they have symptoms, they think it is related to something else. They may feel tired, they may have joint pains, and they don't think it's related to hepatitis C. So that is maybe a barrier for treatment, especially with the older treatments. Therapy-related factors, side effects, or potential drug interactions. There are different treatments and there may be different side effects and drug interactions, and everyone is different. But here it goes, like if someone may have a side effect, then with interferon, for example, that was very common. Interferon had specific potential side effects that not everyone would develop, but people would talk a lot about those, and that would create a big barrier for treatment. Remember now that interferon is not anymore in the guidelines for preferred treatment of hepatitis C. Social economic factors, I would say language barriers. The case that I presented at the beginning is a monolingual Spanish-speaking only patient. If that may be an issue. There may be a lot of cultural differences, language barriers, and that has been shown to be a barrier to care in the United States. And then patient-related factors, which is also a huge barrier for treatment, and not only in hepatitis C, but also in HIV and other infections and other medical comorbidities. Psychiatric diseases such as depression, anxiety, schizophrenia, bipolar disorder, substance abuse, ongoing relapse of heroin, crack cocaine, which may lead to new infections or relapses, not understanding what the disease, what the hepatitis C may do, and lack of education as well. Gaps in care for the Hispanic population. Historically, Hispanics, low treatment completion rates for the reasons that I explained in the previous slides, essentially, among other reasons. But the previous slide explains many of the barriers that have led or contribute to low treatment completion rates in the Hispanic population. And the treatment evaluation should include the risk factors of alcohol use, transfusion, unregulated tattooing, and other causes. Because one of the things, alcohol, again, will not cause hepatitis C, but if someone is drinking alcohol, which is very common within the Hispanic community as a cultural, everyone goes to a party and there is always alcohol and peer pressure, it may have an impact on treatment success, as alcohol may cause liver inflammation, and even if the person takes their medicines correctly, the liver swelling caused by alcohol will not allow the medicines to work the way that they are supposed to work. So it may have an impact on cure rates and decreased cure rates, as an example. And for some reason, they are less likely to be referred to a subspecialist for treatment. And a lot of it is related to the previous slide, some of those barriers to care. And then some things that may affect Hispanics, among other minorities, that may have an impact on cure rates or referral for treatment. So people who inject drugs, few drug users with hepatitis C initiate antivirals because they may not be interested at those particular points in time to start treatment, or the provider, there may be a provider bias in which, because people are actively doing drugs, or even if they are not actively doing drugs, the provider may feel that they are not candidates for treatment, where in reality there is data that people who have used drugs, or even people who actively do drugs, may benefit from hepatitis C treatment and do very well. And again, a lot of it is from, treatment barriers, lack of knowledge about hepatitis C, worrying about side effects, low perceived need for treatment. If someone is actively uncontrolled, in the way that they are actively doing drugs, there may be issues with adherence, and compliance to treatment is very important in order for cure to be achieved. Incarceration may be a barrier, and patients with no stable housing. there may be a barrier where, in those situations, multidisciplinary approaches may help increase successfully the management of hepatitis C and other. And then there are some host factors that may affect. And in terms of the Hispanics, for example, most Hispanics with hepatitis C are men, so the male gender may be associated with accelerated fibrosis and liver cancer. Most are older, although that is changing. There is more younger people getting affected by hepatitis C because there is a epidemic of heroin opiate use right now. And Hispanic ethnicity, again, this was one of the questions. With the Hispanics, there is a higher mortality rate from hepatitis C related cirrhosis, and the Hispanic ethnicity is an independent risk factor for hepatocellular carcinoma related mortality. So high rates of death from cirrhosis and high rates of death from liver cancer. And behavior, again, alcohol use. Alcohol use has been associated with all-cause and liver-related mortality, and in some, I don't want to say in everyone, but in some Hispanic subpopulations, there is a high use of alcohol. Heavy smoking may affect a liver fibrosis progression. HIV co-infection is associated with progression to cirrhosis, liver failure, cancer, and death. Hepatitis B co-infection has also been associated with liver cancer, and there is a vaccine to prevent hepatitis B. The issue of obesity, diabetes, insulin resistance, and hepatic fatty liver or steatosis, that affects Hispanics because in many Hispanics, particularly Puerto Ricans, there is a high rates of diabetes and fatty liver. And in that combination of obesity, diabetes, and fatty liver, and then increased insulin resistance, there is an association of higher risks for cirrhosis and liver cancer. So that may be contributing to why Hispanics, in particular Puerto Ricans, we may be seeing those higher rates of death at earlier times. So, one of the things is, regardless of liver enzymes, even if someone has a normal ALT and AST, they should be referred for treatment. If they have hepatitis C viral load detected in their bloodstream, even if it's low levels, even if they have normal liver enzymes, they should be treated. They should be referred for treatment. This is one of the big mistakes that providers, even doctors, make. The liver enzymes are normal, they don't need treatment. That is not correct. They should be referred and they should be considered for treatment. Liver enzymes such as ALT or AST do not relate or are not related to disease progression. Some people may have cirrhosis and they may have normal ALT or AST because there is no liver inflammation anymore. So that means that there is significant liver disease. And if the doctor or the provider goes by liver enzyme numbers, they will be making a mistake in that sense. And patient follow-up. These are, between 25 and 50% of patients that are referred, they will miss their first appointment for the same reasons. They don't think they are sick, they don't understand hepatitis C, stigma, many reasons, transportation, the issues that I mentioned before. So arranging the appointment for the patient is important, following up is important, and many patients do not follow up with their appointment because they may not be ready to be treated. In terms of treatment, like I mentioned earlier, the treatment options and the length of treatment will depend on the genotype, whether the person has been treated before and whether the person has evidence of cirrhosis. So the treatment is 8 weeks to 24, and these are the treatment options. There is combinations of fixed dose combinations, that is what FDC means, and these are some examples, Basvir or Brazopravir, which is Zepatier. You have probably heard about Harvoni, which is a combination of Leripasvir and Sofosbuvir. And you probably have heard about Vicirapac, which combines 3 different medications, Cimeprevir, Sofosbuvir, Daclarasvir, Sofosbuvir, and then Sofosbuvir and Ribavirin. And there are some others. And the main concept is combining several medications to target different sites at the replication capacity. So by inhibiting replication at different sites, the hepatitis C will not multiply and eventually will be killed and cured. Drug interactions, there may be drug interactions, and this is a site that people may use to look them up, www.hep druginteractions.org, and there are some others. And these are the enzymatic pathways for those of you who are interested: CYP3A4, PGP, PCRP, OATP1B1. There are no major issues with methadone nor Suboxone. Some medications, depending on the ones that the provider may be using, may need to check for potential interactions with antidepressants or anti-anxiety medications or anti-cholesterol medications. And the patient should always let the provider know of any new medications, including over-the-counter and including herbs, such as St. John's wort, for example. As a summary, hepatitis C screening has been expanded to include the baby boomers between 1945 and 1965. Besides the risk factor screening recommendations, the treatment options have evolved. Before 2011, hepatitis C treatment could last as long as a year with cure rates of 40 to 50% for genotype 1. But since then, since 2011, the cure rates are more than 90% with the new direct acting agents that will not require interferon. And the importance of hepatitis C in terms of screening, diagnosing, and referring, because it is a curable disease. It can be cured. And if it's cured, the earlier the person can get rid of it, the less complications in terms of liver and non-liver morbidity and mortality and quality of life. Thank you.
So first off, again, my name is Janet Hernandez, and I want to thank the Latino and Hispanic ATTC, Dr. Daris Orovich, and other staff for putting this important webinar together. And I want to thank Claudia Monterrey for doing a wonderful job of covering many of the important issues that we all need to understand in relationship to hepatitis C, Latinos and Hispanics, and all of the medical issues that are important to that. Just want to briefly mention that there's a lot of research out there that has been published regarding social determinants of health and HCV risk, and so folks are at elevated risk if they live in low-income communities, and we know that Latinos and Hispanics across the U.S., many do. Many have a history of homelessness, history of incarceration. We have made a great deal, and I think in a very timely way, about mass incarceration and the disproportionate of African Americans and Latinos who are incarcerated. So we have a lot of folks who are incarcerated, and those folks, 95% of those folks are coming back into our community, so it's important to mention that. History of mental health conditions or substance use. Again, we've heard from Dr. Monterrey around those issues that are relevant, and they present for elevated risk for HCV. Immigration from regions with increased HCV prevalence, so think about, migration and immigration, people coming from other countries and from other regions of the country, right? Patient populations with overrepresentation of the above. So those things are important for us to bear in mind and to understand during this process. So who should be tested? I think that Claudia covered this really well, so I won't spend a lot of time on it. But we should really think about the folks that are, in terms of the population, priority population that we're talking about here, Latino and Hispanic folks, and who they are, where they congregate, where they go for services, those sorts of things, and how do we target messaging around testing, and how do we think about those messages in a culturally and linguistically competent way, engaging people where they're at, in many times in many non-traditional forms. We know that there are a number of organizations at the community level that are testing people in jails or when they're coming out through reentry programs. They're doing testing at community health fairs. They are providing testing at cultural events and festivals that really target the Latino and Hispanic community. And so those are opportunities to engage the Latino community in traditional and non-traditional ways to get them to become tested and to know their status. And all of the priority populations here to be tested are also recommended by the Center for Disease Control and Prevention. You know, Dr. Monterrey also talked about current treatments and very high cure rates, 95 to 99%, over 90% for most people. But, you know, patients should be informed about the low but present risk for transmission with sex partners. And Dr. Monterrey talked about that. So when counseling people, we need to spend some time exploring that with them and not just mentioning it in passing, but exploring that with them. The other piece has to do with sharing personal items that might have blood on them. And this is an important piece because many of the folks that we work with, that we encounter who are Latino, have families, have kids. You heard Dr. Monterrey talked about that. And so, you know, to share with them that toothbrushes might have blood or traces of blood on them. Certainly razors can pose risk to others. And so we should be talking about this with individual clients within the context of their living situation, if that's within a place where they live with family or in a shelter or in a treatment facility or even behind the wall in prison, that sort of thing. Cuts and sores on the skin should be covered to keep from spreading infectious bloods or secretions. And again, spending some time with people so that they understand that donating blood organs, tissues, or semen can spread HIV to others as well. And so, you know, this piece here is really important in relationship to counseling folks. HIV is not HIV. I do a lot of work in HIV, so forgive the mistake there, but HCV is not spread by sneezing, hugging, holding hands, coughing, sharing eating utensils or drinking glasses, or through food or water. And so, you know, to some of us this might be straightforward, but just know that some of the folks that we're working with might not have that information. More importantly, there are a lot of myths and a lot of misconceptions out there regarding HCV and transmission, and so we need to make sure that we cover these in detail with folks. HCV positive persons or persons with hepatitis C should be advised to avoid drinking alcohol because it can accelerate cirrhosis and end-stage liver disease. And again, Dr. Monterrey talked about this. And so it's important to ask the right questions and to engage in a conversation, because some people might deny using alcohol or might say that they drink socially when in fact there might be an issue there or a substance use disorder there in relationship to alcohol. So make sure that when counseling people, you ask the right questions, you engage in a conversation that goes a little bit more in depth. HCV patients should also check with a health professional before taking any new prescriptions. I think Dr. Monterrey covered that very well as well. Patients benefit from joining a support group. So many treatment facilities that are providing HCV treatment, but also some that provide substance use treatment, recovery supports, and that sort of thing, are seeing the need to develop and implement support groups for people because they are dealing with issues of depression. They're also dealing with issues related to recovery from substances, that sort of thing. So counseling people on the importance of joining a support group is important as well. You heard Dr. Monterrey talked about prevalence, and just want to cover a little bit more among injection drug users. And so it's the most common means of HCV transmission in the U.S., that is injection drug use. The most recent surveys of active injection drug users indicate that approximately 1/3 of young injection drug users are HCV infected. So those are ages 18 through 30. And so we heard those data about the baby boomers, but just know because of the opioid crisis that we are experiencing across the country, there are many young people who are becoming infected. Older and former injection drug users typically have a much higher prevalence of anywhere from 70 to 90% of hepatitis C infection, reflecting the increased risk of continued injection drug use. And so it's important to have that in mind and the demographics that we're talking about. The high hepatitis C prevalence among former injection drug users is largely attributed to needle sharing during the 70s and 80s before the risks were widely known and before educational and testing initiatives were implemented on a wide scale. The other piece that I want to mention is that we have a large number of people who are in recovery. And so we know from Faces and Voices of Recovery, that national organization, that there are approximately 23 million people in recovery in the United States. And a large percentage of those folks or a significant percentage are Latinos and Hispanics that are in recovery. Now, if you add that we don't live in isolation, we live with family members, that should give us an indication that we need to reach out to millions of people in relationship to supporting them, encouraging them to get tested, and counseling them on the risks and reducing risks. So in terms of counseling people who use drugs, harm reduction strategies work and keep people safe and alive. And for some people, for some folks, when we talk about harm reduction, including needle exchange, including just counseling people in terms of reducing their drug use, if they're going to use safely, to not share injection equipment or other drug using equipment. For some people that's controversial, but we do know from the evidence and the science that these initiatives around harm reduction do save lives. They do, and we should embrace them when working with people who are currently actively using drugs. And so knowledge of HIV status can be a factor in promoting behavioral change for people. So think about it. Some people who might be in pre-contemplation about their drug use, they might learn about their HIV as well as HCV status, hepatitis C if they're co-infected, and that might be a motivator for them to change their behaviors and to get into recovery. And so we should also encourage people, because recovery is possible through their choice of a recovery pathway. And I want to just pause there for a second to say that there are multiple pathways to recovery. And those include, through faith-based initiatives, to medication-assisted treatment, through outpatient treatment facilities, through inpatient treatment facilities. There are a number of folks who get into recovery by way of the criminal justice system, including probation, parole, daily reporting, those sorts of things. And we should really explore what their recovery pathway is and encourage that and provide supportive services that support positive outcomes in their recovery. Brief screening and referral to treatment and other recovery support services. So think about that as you're working with people, even if you think that these folks might be showing up and testing positive for HCV, and you might not think that they have an issue with drugs and alcohol, but doing a brief screening can go a long way. And then referring people to the appropriate place for treatment is extremely important. Make sure that the referrals are to organizations and or programs that are culturally and linguistically appropriate. I know that I am here in Massachusetts and very close by to Dr. Monterel, and I know that she is bilingual, bicultural. I know that her staff are bilingual, bicultural. And I know that when I send a patient there, they will be treated with dignity, with respect, and with adherence and attention to issues of culture, to issues of language. But there are other facilities in the city where I live in that there are other folks who do that as well. And I think that is our responsibility to figure out who those providers are and to make referrals where people can go and be treated with dignity and respect. And that increases outcomes because you heard about the barriers. And most of the people that we work with come to us and say, you know, you sent me to this place, but no one there spoke Spanish. Or I was there and no one really understood what I was trying to say. Or some people thought that I was lying or being deceitful, and they treated me unfairly because of that. So make sure that you know the places where you're referring people to, and make sure that you have warm handoffs in relationship to referrals. And it's not just giving people a piece of paper and saying, here, go there. In many cases, you know, I provide a phone number. If needed, we sit down with people and make a call for them or with them to initiate that process. And for some folks, you know, we make arrangements for transportation. So those are things that are important, not just for people who use drugs, but for the community in general. In terms of culturally appropriate services, you know, again, back to this piece on the staff, we're looking to send people where there are people who are understanding of their culture, that have bilingual staff, Spanish, English, but remember that some folks from Latin America speak other languages than English and Spanish. So if you're working within an area that has a large Brazilian community, you know that they speak a form of Portuguese. So when making referrals, make sure that you're making it for a place that's going to be responsive to their needs, and that they have translation at all levels of services, and that they're not parentifying children, using them as translators, that sort of thing, as well as calling people in from the hallway janitorial staff and saying, well, you speak Spanish, you can translate for people here. That there's an availability of Spanish language and other language materials, and there's an abundance of materials out there that have been produced and translated that we can use in reaching folks in an effective way, and that our spaces of service are inviting and safe spaces for people to go to, that we adhere to issues of confidentiality, and that we provide the opportunity for people to ask questions. And remember that in terms of Latinos, and I can say this coming from the research, but from professional and personal experience as well, Latinos value have a great value that they place on family and family interactions. And we have a different definition of the nuclear family and who we would consider family. So think about what that means in relationship to having an inviting space and people coming in for treatment, and they might come in with family members and or people that they consider family members who might have questions about what's going on with their loved one. And finally, having a listing of referral sources that are culturally and linguistically appropriate. And you know, you're working within your communities. I encourage people to get out, to speak with folks, to have a listing of Latino community-based organizations, faith-based organizations, health organizations that reach and have positive outcomes with the folks that we work with, so that we can encourage greater engagement, retention, and improve outcomes for the people that we're talking about. So that's my part of the presentation. Now we're headed for this time for questions and answers.
Okay, so can you hear me?
Yes.
Okay, we have a few questions from the audience, and I believe this was mentioned, but we can go over it again. What is the most common way that hepatitis C is transmitted to the body? Hey, can you hear me?
Well, yes, I talked about injection drug use, so I want to pick it up there and then give it to Claudia, and she can talk about other ways. But most common ways in terms of folks who use drugs is through the sharing of either injecting equipment, which includes needles, cookers, cotton, even things like crack pipes that people put to their lips that might have blood on them, that sort of thing. And so that can easily, transmit the virus from one person to the next. And so for people who use drugs, those are some of the ways. We also talked about the fact that HCV or hepatitis C can be transmitted through sexual intercourse, and that can be from male to female, but it can also be for men who have sex with men. Those sorts of things are extremely important to cover with people, even though we say that those risks are low. They are still risks, and we should cover those with people in terms of infection. Claudia, do you want to add to that?
What is the question again?
What is the most common way that hepatitis C is transmitted to the body?
The most common way right now in the United States is intravenous drug use. Intravenous drug use, and it would be heroin, opiate drug use.
Perfect. Okay, so we have another question. You mentioned that there was an increase in HCV mortality rates as compared to HIV somewhere around 2005. Are there some possible explanations?
Yes. What has happened with HIV is that there is better medications. There is more knowledge about HIV. The medications for HIV are safer, more effective. People with HIV, HIV is a chronic disease. People live longer and better. So the mortality in the past, the medication, there was not a lot of knowledge, and the medications were not as effective, and they were more toxic. So people would die more of AIDS. Now people live longer, so it's more of a chronic disease. Hepatitis C, what has happened is the opposite. the medications back then were interferon and ribavirin. The cure rates were about 50% for genotype 1. So a lot of people were not treated or would not be willing to go through treatment because of the side effects of the medicines. And a lot of people would develop then the consequences of untreated hepatitis C, such as liver cirrhosis, cancer, liver failure, and death. So what has happened, after 2005 is that the mortality rate of hepatitis C has gone up as a consequence of more people dying from liver-related, complications from hepatitis C. That may soon revert with the new treatments, but it will take a while because there is a significant amount of people with liver fibrosis and liver cirrhosis and people waiting for liver transplants right now. And even if those patients with liver cirrhosis and people who are waiting for liver transplants get treated and cured, the effects of the liver damage is already done. So, the main issue would be treating them, of course, but also treating people early so that they don't develop those complications from not getting treated and prevent development of complications and that way avoid death.
Mm-hmm. Thank you. Thank you very much. Okay, we have another question. What qualifies homelessness as a risk factor for HCV? Is it related to IV drug use?
The issue of homelessness is the risk factors that are associated to someone being homeless. It doesn't mean that everyone who is homeless will use drugs or will use alcohol or, will have risk factors associated to that, but the data shows that they are at an increased risk because of those other risk factors that may lead to getting infection with hepatitis C. A lot of unregulated tattoos or drug use or mucosal exposures of hepatitis C through contaminated blood. Hanner, I don't know if you want to mention anything else.
No. I think that covers it. And so homelessness in and of itself is, many people are homeless. They're not going to become hepatitis positive, but it's the behaviors that are associated with some of the folks who are homeless that we are concerned with. And so those are the things that we need to target in on and address with people, as well as the providers who are providing shelter, food, and those sorts of things for the homeless. Because there's an opportunity for us to reach into and work with those providers to say, listen, this is an issue. HCV, hepatitis C is an issue. You might want to put out some information about getting tested, where people can get tested, that sort of thing. And treatment is available, all of that stuff. And so there are opportunities for collaboration as well.
Mm-hmm. Okay, great. Thank you. We have another question. How long does HCV stay active after exposure?
So again, when someone gets infected with hepatitis C, people initially get acute hepatitis C, which may last up to 6 months. If the person is not able to get rid of the infection by themselves without the need of medication, then the hepatitis C becomes chronic, and that would be after 6 months of infection, and the person has hepatitis C forever unless they get treated with medications. So I think that is the question. That would be the answer.
Mm-hmm. Okay. Thank you. Let me see. Okay, so we don't have any more questions at this time.
I'd like to mention something that we haven't covered, and it has to do with Latinos, and there are a number of a large number of Latinos and Hispanics throughout the United States that might not have health insurance coverage. And so we know that through the Affordable Care Act, millions of people across the United States have gotten access to coverage, healthcare coverage. And so I just want to mention that because we keep talking about testing and treatment, but you know, as soon as you go into any place, especially for treatment, they're going to ask you or the person if they have insurance. And so on the front end, it pays that even before you're referring people to treatment to ask that question. And then if they do have insurance, fine. If they don't, to figure, and you know, different states have different things that are available, and they operate, you know, in different ways. So I would ask you to look inward to your own state, to your own city, town, or neighborhood, and look at the different resources that are available to getting people the health insurance that is going to be required for them to receive HCV treatment and care moving forward. So just, you know, would be remiss if we didn't mention that within the context of working with Hispanics and Latinos.
Mm-hmm. Let me see if we have another question. Thank you, Hanan. Okay, how long can the virus stay living on a surface?
Oh, okay. So there is some data that shows that it could survive in a surface up to 30 days.
Mm-hmm. Okay. Okay, thank you. That's all the questions we have for now. And as I mentioned before, if we get more questions by the end of the webinar, or if someone sends us an additional question, we'll send it to our presenters and we'll post them on our website. So at this time, I would like to thank our presenters, Dr. Martorell and Dr. Haner, for a wonderful presentation. And just a reminder for our audience, a recording of today's webinar along with the PowerPoint slides will be available and will be posted on our website at www.attcnetwork.org/Hispanic Latino. It will be approximately 1 week from today. You can go to our website and you'll find the recording. Also, your feedback is very important to us. So as we finish the webinar, you will be directed to complete a brief survey about your experience. So if you could please complete that, we appreciate you taking the time to tell us what you thought of today's webinar. And remember that if you're interested in obtaining CEUs from NADAC, MVCC, or ICNRC, you may email us again at Hispanic Latino attc@uccaribe.edu. So that concludes today's webinar. So thank you, everybody, and we hope that you enjoyed it. Thank you.